Good afternoon. We have a very interesting session on the management of uveitis. Uveitis, as we all know, is mostly dealt by general ophthalmologists to a large extent. So it's very important we all know how to optimally manage this disease without causing any complications. So we have a vast array of speakers. I invite my co-chairperson, Dr. Anuradha, who is a senior consultant and HOD of uveitis at Aravind Eye Hospital, Coimbatore. And I also invite Dinesh Talwar sir, who does not require any introduction in this forum, to moderate the session. Sir, please. So Dr. Anuradha will be talking to us on uveitis systemic evaluation, how to go about it.
Good morning. It's coming to Calicut is like coming home, because I have a relationship with this city which goes back to almost 40 years, right from my school days. So let me begin by thanking the organizers of Drishti and Dr. Srini for asking me to be part of this program. Thank you. So the topic is systemic evaluation in uveitis, and there are many reasons why you might want to do a systemic evaluation in uveitis, including as part of your pre-treatment workup or for monitoring side effects. But probably the single most important role of systemic evaluation is to help you with the diagnosis of uveitis. So suppose somebody were to try and communicate with us and couldn't speak. I think most of the information would come from looking at their face and their hands, right? So I'm going to concentrate on the findings or signs which you can pick up from examining the face and hands of a uveitis patients. The reason why is it's easy to do this. You don't have to ask the patient to undress. You don't have to subject them to imaging or any invasive procedure. So here you have a young man coming with pain, redness and photophobia in the left eye. He's got an anterior uveitis. The cause for the uveitis is very evident. You have this pigmented rash. Strictly respecting the midline, and you know it's herpes zoster ophthalmicus. But sometimes the ocular inflammation can happen either concurrently with active exedo, or it can happen many months or years later when the scars have resolved. And you may not be able to see the scars very clearly. So any patient who is coming with unilateral recurrent keratitis, keratouveitis or uveitis, particularly when associated with sectoral iris atrophy and increased IOP, you should look for and ask for past history of herpes zoster. So this next patient is a patient with Hansen's disease. You can see that there's a total loss of eyebrows and eyelashes. He also has a collapsed nasal bridge. The ocular inflammation in Hansen's disease primarily affects the... No? I was talking about the total loss of eyebrows and eyelashes in the Hansen's disease patient. And like I said, the ocular inflammation in Hansen's primarily affects the anterior segment. The posterior segment is relatively spared. And the uveitis in this case, it tends to be chronic, and you get this very diffuse iris atrophy like a moth-eaten iris with extensive synechiae and cataract formation. Next patient. So our next patient is a weak age patient, and you can see this whitish discoloration of the eyebrows and the eyelashes, and also those white patches on the upper and lower lids. The whitish discoloration is called poliosis. Typically it is seen in weak age. Sometimes you can see it in sympathetic ophthalmia as well. Now you know that weak age has different stages, and most of your patients are going to come to you in the acute exudative detachment phase where they have sudden loss of vision. You're not going to see the skin changes or hair changes in that phase. That changes happens in the convalescent phase or recurrent chronic phase. So in the eye, you have to look out for this sunset glow fundus, or the patient might have recurrent bilateral granulomatous anterior uveitis. You can also see these patches in the Hansen's disease, the same patient which we saw before. Also note the loss of digits. So inflammation of the nasal cartilage causing a collapse of the nasal bridge resulting in saddle nose can be seen in many different inflammatory disorders, including Hansen's, granulomatosis polyangiitis, congenital syphilis, and relapsing polychondritis. Now you see this lady at different times she has presented with diffuse anterior uveitis, peripheral keratitis, and later with an exudative retinal detachment. Her diagnosis is actually written on her face. You can see the collapsed nasal bridge. Also note the ears, it's floppy, deformed, and she gave past history of recurrent pain and redness in the root of the nose and the earlobe. Now you'll all remember this butterfly rash or mala rash from your MBBS days. It's part of the diagnostic criteria for SLE. SLE's most devastating complications happen when you get a retinopathy. This is occlusive vasculitis. And it's important to recognize this because this actually correlates with the disease activity in the body and indicates a bad prognosis for the patient. My slides are ahead of me. Coming to the importance of asking for recurrent oral ulcers, I think all of us have children, would have had aphthous ulcers, but this is a very important part of clinical diagnosis of Behçet's. Recurrent oral ulcers, more than 3 episodes in a year with recurrent genital ulcers as part of the diagnostic criteria. The oral ulcers in Behçet's, they tend to be painful. I want to underline that. They're shallow, they can be multiple, and that can affect any part of the mouth. They can also have skin changes like dermographism and a positive pathogy test, which is a papule or a pustule developing after intradermal needle prick. The eye involvement in Behçet's can take the form of a non-granulomatous anterior uveitis with a hypopyon, as you can see here. But again, what causes visual debility is when the posterior segment is involved in the form of retinal infiltrates and occlusive vasculitis. In contrast to the ulcers which you see in Behçet's, the oral ulceration in primary syphilis, also called chancre, is painless. And you can also see that the margins are elevated and indurated. In the secondary stage of syphilis, you can get this unusual rash on the palm and the soles of the feet. They're copper-colored papules. Very rare to get rashes in the palms and the soles. Now coming to scleritis, the most common systemic association for scleritis is rheumatoid arthritis. It is a painful, deforming arthritis which primarily affects the wrist and the hands. So in advanced stages, you can see these changes, including the ulnar deviation of the metacarpophalangeal joints. What is called a swan neck deformity, where you get a depression of the proximal interphalangeal joint and an elevation of the distal interphalangeal joint, resembling a swan's neck. And the opposite, in Bottineau deformity. You may also see these painless subcutaneous nodules, mainly over the fingers and wrists, and they're called rheumatoid nodules. Coming to the last case, the most common association for anterior uveitis is seronegative spondyloarthropathy, and typically they are unilateral or a bilateral recurrent alternating with hypopyon or fibrin formation, and the strongest association is with ankylosing spondylitis. But you also need to look out for psoriasis and psoriatic arthritis. So you get this reddish or purplish elevated plaques with white or silvery scales on it. And the psoriatic arthritis, in addition to the axial skeleton, also can affect the peripheral joints, and they typically affect the distal interphalangeal joints and can have nail changes like pitting, ridge formation, and a separation of nail from the nail bed. Now, I know that this list is incomplete, but it's difficult to, cover everything. So for those who are interested, you can look up this article published in IGO in 2013. And one of the biggest joys of working in uveitis is, is the ability to connect the dots and come up with a diagnosis that makes a lot of difference to the quality of life of a patient. നമ്മുടെ ബേപ്പൂർ സുൽത്താൻ പറഞ്ഞ മാതിരി ഒന്നും ചേർത്ത് ഇമ്മണി വലിയ ഒന്ന് കണ്ടുപിടിക്കാൻ പറ്റുന്ന കഴിവ്. I hope this talk has been useful. Thank you for your patient listening.
Thank you, madam, for that excellent talk covering the spectra of uveitis in such a short time with fantastic photographs. Thank you, ma'am. Next is my talk on periocular treatment, local treatment of uveitis. So as we all know, this is the most common modality of treating uveitis, but you have to be very careful when we use these drugs. We have, coming to the local ocular treatment, we have the most often used, that is the topical corticosteroids. Then we have the adjuvant treatments like periocular injections and intravitreal injections. We will look at how we use them judiciously without causing any harm. So when do you use topicals? Mainly for anterior uveitis. Always start with topicals, and sometimes whenever you have pan-uveitis or posterior uveitis with spillover AC cells, and also in cystoid macular edema. So any form of steroid treatment, the main principle is always hit hard. Start with the maximum dose. So usually it is started 2 hourly, even if it is mild to moderate uveitis. And for severe cases, you may go up to half hourly or even once in 15 minutes. And you should not drag the treatment of steroids more than what is needed. So you have to start tapering at the right time. Usually the clue is whenever you have the grading decreases by half. For example, 4+ cells become 2+ cells. That's the right time you can start tapering steroids. And certain cases, very rare cases like JA and all, you may have to maintain patients on a very small maintenance dose, that is less than 1 drop, which does not cause usually any complications. And before using steroids, you should understand the pharmacokinetics, how it is for topical steroids. Mainly all steroids get into the anterior chamber through corneal diffusion. It is not the potency of the steroid, but the concentration that is achieved in the AC that causes the anti-uveitic efficacy of the drug. So that has to be remembered very clearly. The formulation tells a lot, because gel has better absorption into the AC than suspension, which has got more absorption than solution, and ointment has the least form of absorption. Also the salt what is used, for example, prednisolone acetate has more absorption into the aqueous than phosphate form. And also the vehicles used, petrolatum example in ointment, that prevent absorption of steroids. And concentration and dosing frequency also, as the concentration increases or dosing frequency increases to a certain extent, the anterior chamber concentration also increases. So prednisolone acetate is the most often used drug by most of the uvea specialists. Every 15 minutes gives the maximum efficacy. Beyond that, if you increase the frequency, it is not going to increase the aqueous levels. And 1% also is optimum concentration, beyond which it does not have any other potency. And even though it is a weaker steroid than betamethasone, it has got almost more than 100-fold potency than betamethasone when used for uveitis. And this is a common mistake I saw yesterday also. This is the most common mistake I see, because antibiotic steroid combinations are being used for uveitic treatment. It has got 2 big problems. One is the antibiotic in the steroid, it affects the pharmacokinetic. It does not cause the desired aqueous concentration of the steroid. Also it increases microbiologic resistance. Difluprednate is another option, better option, because it has got more potency than prednisolone acetate. It's an emulsion form. Predacetate is a suspension, so always you have to shake that before use. And emulsion does not require that, and it can be used at a lesser interval, like 4 times per day, to give the equal efficacy. And another issue is subconjunctival steroid better? No, it is not better, because many drugs has scleral penetration, but steroids are not a group of drugs which go through the sclera. They only go through the cornea, because they are lipophilic. So there is no role for subconjunctival injection. And these are the other drugs which we have, but most of the time treatment is with prednisolone acetate. And even though topical steroids are the most used, they have their own side effects, so we have to be very watchful, or ocular hypertension. rise in intraocular pressure, 4 to 6% of general population are high responders. They can go up to beyond 30 millimeters of mercury. So you have to be very watchful, and especially patients of primary open angle glaucoma, you have to monitor them very closely. But the advantage is once you stop the medicine, it resolves the IOP gets under control within 2 to 4 weeks. You can use milder steroid also to get away with this problem. Cataract is again one more problem. Many times we see cataract due to drops rather than the uveitis. So if you are going to use more than 4 months, more than 2 times a day, then it is going to cause cataract. And we have other complications of steroid like corneal epithelial toxicity, exacerbation of corneal infections, crystalline keratopathy, and inhibition of corneal wound healing. And also you have to remember systemic absorption is significant, especially in children. If you use for a long time, they can even cause Cushingoid syndrome. So you have to be careful in children. Periocular steroids is the next step on management of uveitis. So moderate to severe uveitis, which is not responding adequately to topicals, you may have to use periocular steroids, and cystoid macular edema is another indication where you may have to use. So the most common form we do is the posterior subtenon injection, or the PST, which is a Smith and Nozick technique, which is followed by most of us, where you inject the drug triamcinolone acetate beyond the posterior subtenon into the posterior subtenon space in the superior temporal quadrant, with eye moving side to side without causing any perforation. And as I told, 40 milligram triamcinolone is used most often. And then the next option, adjunct option, is intravitreal pharmacotherapy. So again, triamcinolone is the most often used drug for this also. Here the advantage is it gets a very high concentration very fast, so I have an immediate therapeutic effect. And another option that we have now is a Dex implant, which is a sustained release dexamethasone, 0.7 milligram. Theoretically, it has much higher anti-inflammatory potential than triamcinolone. The implant gradually releases itself, the dexamethasone, for 6 months, and at least you get 2 to 3 months efficacy with this. PST also gives 2 to 4 months efficacy. Huron trial was one trial which showed the efficacy and safety of this form of treatment, and usually this is done under topical anesthesia. Here I am giving a subconjunctival injection, but it's not required. This is the pre-filled, preloaded syringe, and you have a safety valve here which has to be pulled, and there's a cap, and you have to remove both before injecting, and you have a 22 gauge needle here attached through which, through the pars plana, you inject the pellet. Usually the bevel has to go down towards the macula, and it is injected downwards. So you can see the drug going once there is a trigger which once you press that, the pellet is released into the vitreous cavity. So it's a very easy procedure. So which is best now for the adjuvant treatment? It is this point trial compared 40 milligram posterior subtenons versus intravitreal injection of triamcinolone as well as dexamethasone for a 6 months duration, and we found that all treatment group had improvement in CRT, central retinal thickness, as well as macular BCVA, but the extent of reduction was more in the intravitreal group compared to the subtenon group. And there was no difference between IVT in the tricot versus Ozurdex as far as macular edema and central retinal thickness was concerned. And complications, the severe response, the high responders, more than 30 millimeters of mercury was not seen, was equal in all treatment groups. But myopia more than 24 was slightly more in the intravitreal treatment group. So to conclude, both the modalities of treatment are effective, but intravitreal treatment has a better advantage as far as BCVA and central macular thickness is concerned. And other options we have is anti-VEGF injection. There are only very small studies, and some studies even have showed it is not effective, but it is something which you can consider, especially in people who are steroid responsive. And intravitreal methotrexate, we use it for intraocular lymphoma mainly, but it has been found to be effective for macular edema, and there is advantages, no risk of glaucoma or cataract. There is corneal epithelial toxic, especially in aphakic eyes. Another advantage is being an antifibrotic. It has advantage, it acts against the CNVM also if it is associated with uveitic CNVM. The other drug is a newer sirolimus, which can be given both subconjunctival as well as intravitreal, and these studies SAVE-1, SAVE-2 and Sakura trial has shown good efficacy. They also have the advantage of not causing ocular hypertension and cataract. Adalimumab, the TNF-alpha inhibitor, that is also under evaluation for this mode of treatment. So coming to the end, periocular treatment in uveitis has to be targeted. You have to look where the inflammation maximum is, what is the complication, and so you have to target your treatment very well, and you have to use judiciously, even though they may appear mild. You have to use it judiciously so that you get the optimal effect, and you should always be watchful for the complications. Thank you.
Thank you, Dr. Prakash. I think we'll finish all the lectures, and if there is any time, we'll take questions later on.
Yeah, we will finish all the lectures.
Now we have Dr. Ajay Arora, who's a senior vitreoretinal consultant at New Delhi He's going to talk about the role of suprachoroidal steroids. So we've talked about the other forms of delivery, and he's going to tell us of a new form of delivery which he believes is very safe.
Good afternoon, and at the outset I must thank KSOS and Dr. Srini for giving me this opportunity of coming to Drishti 2022. Dr. Prakash has already just talked about the role of intravitreal periocular steroids. I'll be discussing something which I have been working on, the delivery of steroids into the suprachoroidal space in various conditions of macular edema. And it's really shown us good response. I will be particularly talking about intermediate uveitis in this particular lecture. So these are the various routes by which the drugs can be given to the eye. You can either give them topically, periocular, intraocular. The best practical route at this point of time is intravitreal because it takes the drug closer to the retina and the choroid. But it has caused complications like cataract, glaucoma, endophthalmitis, retinal or vitreous hemorrhage, vascular occlusion, and retinal detachment. Normally, suprachoroidal space is a potential space and cannot be visualized, but in some cases, you can visualize the suprachoroidal space on an OCT. So, when a drug is given into the suprachoroidal space, like this latex blue dye, which was injected in the suprachoroidal space, it spreads almost instantaneously and occupies almost 50% of the suprachoroidal space, which basically means that the delivery to the posterior segment of a drug injected in the suprachoroidal space is quite extensive. Also, we can inject a larger volume. It's been theoretically said that you can actually go ahead and inject almost up to about 1 ml fluid. We never inject that much, but yes, it can be done. The basic problem is that it is a blind procedure and it is in a potential space and needs proprietary microneedles. There have been various studies to show that Zuprata, which was CLSTA, which was made by Clearside Biomedicals, which has been shown to be useful in cases of intermediate uveitis, and multiple studies which have shown the effectivity, and it is beyond this thing that it works. It definitely works. And you must remember that when you inject a drug into the suprachoroidal space, this space is blocked anteriorly at the level of the ora serrata and posteriorly at the level of the optic nerve. So it does not theoretically cause glaucoma, it does not cause cataract, and it delivers the drug to the posterior segment. The problem are that there is a proprietary methodology available by the Clearside Biomedical, and this costs a lot. One injection may cost, it's not yet available in the country, but may cost anything over 30,000 rupees, and a microcatheterization of the suprachoroidal space by Med1, which has now been discontinued. Then you have this jugaad which people have done, and many of you may have attempted it, of using a 23 gauge and a 30 gauge needle, making a needle out of it which projects about 1000 microns beyond the needle tip, and that goes perpendicularly into the suprachoroidal space. But then if you have injected it and seen that it may not actually every time inject the drug. So what we said was, what we thought was, can we inject with a normal 30 gauge needle into the suprachoroidal space? Can it be safe? So we did a study where we thought we'll construct a device which can inject the drug into the suprachoroidal space. We also thought that, is there a claim which may be made by Clearside that Zuprata is better than the triamcinolone available in our country, and to test the ease and safety of injections in the human eyes, and I'll just rapidly go through it. So this was the scanning electron microscopic studies we did, and we found that Orocort is as good as Zuprata. So there is no reason why you should be thinking of Zuprata. So this is Zuprata, and this is Orocort scanning electron microscopy, and it goes to a 30 gauge needle. We constructed this device which is used for suprachoroidal injection, and we did animal experiments, and you see this is a goat's eye, the injection being done. You will see the injection being done into the suprachoroidal space. Then I will dissect out the suprachoroidal space and demonstrate that the drug has gone into the suprachoroidal space. We also inject it in the goat's eye. You can see here this whitish material, which is triamcinolone. And then we did a UBM analysis of triamcinolone into the suprachoroidal space, methyl cellulose and helon, and you can see here the suprachoroidal space is expanded by helon. We went ahead and did the human studies, and therefore this you can see here that the device is being used when injecting into the eye. This normally I inject it in the infratemporal or the infranasal quadrant. We did OCT analysis of the scleral thickness and found out that these two quadrants are the best to choose, and we have nomograms for the device to choose based upon the thickness of the sclera. So these were the preliminary studies, and you can see here this was a diabetic patient who had received anti-VEGFs and Ozurdex, and you can see the amount of edema in the right eye and the left eye. There was a time in the country when Ozurdex was not available, but at that time we were ready with the device, and you can see how beautifully the macular edema subsides after suprachoroidal injection. This is pre-SKITA. This is 14th day after SKITA, 34th day and 70th day. So we found from this study that the preservative-free triamcinolone can be safely given by the suprachoroidal device using a 30-gauge needle. We also demonstrated the effectivity and safety of SKITA in varied pathology. So we had I have almost about 98 eyes, and we have had a follow-up on these patients, and it is effective for about 88 days. We did this small study on uveitis, where all our patients were on anti-glaucoma drugs. None of the patients developed any retinochoroidal injury and required any filtering surgery. Then we went ahead and did something more. We thought that we want to increase the effectivity of our triamcinolone. So I bought a centrifuge and started centrifuging the triamcinolone. And of the 1 ml of Orthocort, we used to throw away 0.8 ml, take 0.2 ml, and then inject 0.1 ml of this, which means we are injecting almost to the level of anything from 15 to 20 milligrams of the drug into the suprachoroidal space. So we did a study which was a small one, certainly a small number. 9 suprachoroidal centrifuged triamcinolone injections were given in 4 eyes. I will share the data with you and show you how they work. So this is a patient with an intermediate uveitis who received triamcinolone. The effect lasted for 4 months. You can see here the edema has subsided. The effect lasted for 4 months. The macular edema recurred after 4 months. Then we gave a centrifuged triamcinolone to the same patient. This was injected in June 2020, and we followed up the patient, and this went up to January 21, and sometime next year in March, the patient's edema came back. So it lasted almost for 8 months, which is almost double the time of what Ozurdex lasts, and it cost you virtually nothing. And then we injected again, and next time the effect lasted for almost 7 months, and this patient has now been on the last injection, as I followed up almost for about 8.5 to 9 months, and she has not recurred. This is another patient who I had treated in 2014 with systemic steroids. Patient had uveitis, was a case of was shown to be a case of TB positive, sarcoid negative, and this patient was treated with SKITA. He said, I will not take systemic steroids. We gave him SKITA, and the patient responded well. So this is the results of those 3 patients which we have followed over the period of time. And from this we found that centrifuged triamcinolone could be safely and consistently injected through a 30-gauge needle. The correct placement, the moment you are in the correct plane, the suprachoroidal, in the suprachoroidal space, the drug flows. If there is a resistance, you are not in the correct plane. If you inject in the horizontal plane, there will be pain. So do not inject in the horizontal plane. We put the patients on anti-glaucoma drugs, drops, but we generally stop them in about 3 to 6 weeks. So centrifugation has allowed us to extend the period of effectivity to almost 7 to 8 months and extended the duration of action, and seems to be a promising treatment. This is a small sample study. We need to enlarge it, and maybe Arvind and other institutions could get involved and do this study. It will be very useful. The only risk is risk of infection. We do not know the orocort which is applied to us or any other drug which you use should be sterile. So if you inject on the suprachoroidal space that it is not, that is the only danger. Thank you very much. If you have any questions, I'll be happy to answer. I have a small non-academic slide. I want to share it. And this is a non-academic slide. Me and Rajesh are standing for elections next year. That's the only way I can communicate with you. He'll be secretary. I am standing for treasurer. Would like to see your support. That's all. Thank you very much.
Thank you, Dr. Ajay Arora, and it's nice to know about newer modes of delivery of local steroid. Thank you once again.
Thank you.
I would like to call Dr. Minija for her talk on systemic steroids and its optimal use in uveitis.
Dr. Vinija is the head of the Department of Uveitis at Changara Eye Hospital, Bangalore.
Good afternoon, everyone. At the outset, I would like to thank the KSOS and Dr. Srini for inviting me to a part of the session on uveitis. So my topic is systemic steroids and optimal use in uveitis. And we know that steroids is a class of drugs which acts rapidly and as quickly to bring down the inflammation. So why do we use the steroids? It's an indispensable and an inflammatory agent in the management of uveitis. It's always used in posterior segment inflammation, associated with systemic disease, bilateral ocular disease, and even in infectious etiology. In infectious etiology, usually it's used as an adjunct to the oral steroids. It is also indicated if any times the periocular or the intraocular steroids are contraindicated. And of course, all of us know the drug commonly used is prednisolone, used orally for uveitis. The dose usually is initiated at the dose of 0.5 to 1.5 milligrams daily, followed by a slow taper once the inflammation is under control. So it should be tapered at an interval managing twice weekly to every 2 weeks. Optimally, the dose should be less than 0.1 milligrams daily within 3 months of initiating therapy. Sometimes for immediate control of vision-threatening diseases, we can use intravenous methylprednisolone. Succinate can be given. That is necrotizing scleritis or a bilateral serous detachments. So this is there's a medical management of uveitis published in Indian Journal of Ophthalmology by Kalpana Murthy et al. So they have given how do you taper the oral steroids. You can look through it. I'm not going to tell you in detail how do you start the start of oral steroids, how do you taper, how many milligrams weekly, bi-weekly, based on that. And of course, what are the additional drugs, supplemental drugs you use along when you're treating the patient with oral steroids. So hit hard, hit fast, and don't taper too quickly. That is the dictum of oral steroids. I would like to take you through a representative case series where your oral steroids is very important in treatment of uveitis. Of course, anti-uveitis, we always think that, of course, topical steroids is the one only. But no, sometimes there's a patient of 39-year-old male presented with complaints of pain, drop in vision into almost hand movement in one eye. You can see in the photograph, pupillary membrane, severe reaction, and the vision is dropped. You cannot see the fundus evaluation because the pupil is not dilating. B scan was normal. So this patient, the investigation, we started on topical steroids. Investigation was done. HLA-beta-27 was positive. And since the inflammation is very severe in this patient, sometimes when we don't start the oral steroids on time, it can give it to a complications, a sequelae of uveitis like the posterior synechia. People don't dilate. And you can later on have, iris bombay, glaucoma. So this patient was treated with oral steroids, and you can see the response, he responded very well. So the next case is in choroiditis. So we know that we use even in choroiditis, posterior segment involvement, as I was telling, 31-year-old male, decreased vision OU. On fundus evaluation, you can see those multiple yellowish lesions, which is along the arcades. I think more significantly seen in autofluorescence. Of course, autofluorescence is very important in uveitis. You can see the active lesion. So this patient, again, was investigated. Of course, investigation is very important in uveitis. So it was investigated. and all the tests were negative, so hence we were started him on oral steroids because you know this is a progressive disease, you can threaten the macula and cause decrease in vision. So it's very important. We have seen a lot of patients losing vision because they have not initiated the treatment at the right time. So we need to start them on oral steroids. So this was the patient treated, 2 months follow-up, the vision improved and you can see the lesions healing. So this is a 2 months right eye pre and post treatment, and this is the left eye. So it's again another case of a choroiditis, that was a serpiginous choroiditis. Now you have a 32-year-old male, again decrease in vision, anterior segment is normal. You can see the multiple yellowish white lesion along the superior arcades. The autofluorescence shows some of the healed lesions and some active lesions. On investigation, this patient was Montos positive, IGRA positive. So he was started on antitubercular drugs because he had the ocular sign, all the other features suggestive of ocular tuberculosis. So this is what I was saying, sometimes you have to use it as an adjunct along with the antibiotics. So here antitubercular therapy was started and the oral steroids. And why oral steroids is important? Because we know that it's more a hypersensitivity reaction sometimes. You have to bring down the inflammation. And sometimes they can have a Jarisch eczema reactions and again aggravation of the inflammation. So we need to put them on oral steroids. Of course, the tapering is going to be a little slow. So this is a patient treated with the oral steroids and ATT. You can see the healing of the lesion. The autofluorescence shows the lesions is healing. So it's another case, 34-year-old male, decreased vision in the left eye, 660. Anterior segment showed AC cells of 1+. You can see a granuloma along the inferior quadrant. And there was cystoid macular edema. On investigation, his Monto was negative, but IGRA was positive, and HRCT showed opacification in the right upper lobe, suggestive of an old infection. So this patient also was started on ATT and oral steroid. You can see the resolution of the granuloma, resolution of the macular edema showing the hard exudates, and there's a montage of the same patient. So this indication in serpiginous choroiditis and serpiginous-like choroiditis, so both we might have to use oral steroids. This is a case of a 32, now infective etiology. So do we use steroids in infective etiology? 36-year-old male, decreased vision. You can see a heel, there's a sad scar, heel scar, then next to that is an active lesion, which is suggestive. All of us know that it is a toxoplasma retinochoroiditis. So do we need to use oral steroids in this? Yes, because sometimes the inflammation is so severe, you have to bring down that because sometimes the antibiotics doesn't help. So you have to treat along with the antitoxo treatment and the oral steroids, and of course the dictum is stop the oral steroids and later the antibiotics, not first the antibiotics and later the oral steroids. So this is a follow-up of the patient. This is another patient of toxoplasma retinochoroiditis. You can see the active lesions, which is the OCT showing the same, and this is post-treatment. Now post-fever retinitis. I know all of us have come through a lot of cases of post-fever retinitis. So this is a 32-year-old male, came with decreased vision, history of fever 1 month ago. You can see this retinitis lesion along the arcade. All the investigations were negative. We know that it's self-limiting disease. It might resolve by itself. But yes, starting oral steroids is fasten the decrease in inflammation and improvement in vision. And this is a patient 6 months follow-up post-treatment with steroids. This is another case of post-fever retinitis treated with oral steroids. So next case is, there's a 23-year-old male came with decreased vision, CF 2 meters, and fundus picture shows multiple placoid yellow lesions along the posterior pole. The FFA showing early hyperfluorescence and later leakage, suggestive of acute posterior multifocal pigment placoid epithelopathy. Of course, all of us know that it's self-limiting disease, but when the vision is very low, we might have to use the steroids in this patient too. So this patient was treated with oral steroids, and this is post 2 months follow-up of the same. Then another classic case, the Vogt-Koyanagi-Haridas disease. There's a patient also came with complaints of decreased vision. The OCT shows characteristic features of VKH. And this is a fundus fluorescein angiography also shows it's a case of VKH. This patient, of course, in VKH, sometimes we might have to, if the bilateral serous exudative detachment is very severe and the reaction is very severe and the vision drop is too much, we might have to start them on intravenous methylprednisolone as a pulse dose therapy followed by oral steroids in this patient, and this is on treatment. You can see the deep pigmented fundus. The intermediate uveitis, yes, sometimes do we use this patient, if you see the fundus, it's absolutely normal. Vision is just 6/9. So always we think, do we use oral steroids in this patient? But FFA is showing significant leakage, cystoid macular edema, and there's a capillary leakage. So these are the patients which we know that, we have to use oral steroid to bring down the inflammation so that it doesn't progress further. I'll come to a scleritis. Again, there's one more indication in uveitis. The 54-year-old male presents with pain and redness, 6x vision. OD was unremarkable. The left eye showed scleral congestion and the scleritis. So as usual, we started the patient on topical steroid. There was no response. So investigation was done. He was ANA positive and he was started on oral steroids. So this is again an indication in scleritis which is not responding to treatment, and if it is an autoimmune disease, we might have to start them on oral steroid to prevent the frequent attacks of scleritis which can cause a lot of complications. This is another male, 32-year-old male, presented with decreased vision. And of course, next is a vasculitis. There are various indications in vasculitis. So this is a case of Behçet's vasculitis, HLA-B51 positive patient. And this was a case of another case of vasculitis, where TB vasculitis. So again, this is plenty of indications where, you need to use oral steroids. So this is another patient with vasculitis. So in conclude, corticosteroid is the first line of therapy in non-infectious uveitis, used with antimicrobial therapy in infectious uveitis, and of course, I've not put in the complications of oral steroids. We need to always watch for systemic side effects whenever we put the patient on oral steroids. And important is how do we taper the steroid is very significant, because the optimum dose is very important. Just not starting on 30 milligrams and tapering in 1 week, no, because we see majority of the people starting, because everybody feels uveitis is steroids. So they just start on the not suboptimal dose of steroids, so that it doesn't respond. So it's very important to see what dose we are starting with and how do we taper the steroids and how long we keep the steroids and when do we add immunosuppressives to this thing, because we cannot keep the steroids for a long time. Thank you.
Thank you, Dr. Mineja, for that wonderful talk with the illustrative cases. Unfortunately, Dr. Anup is away, and Dr. Prakash is going to do the talk on immunosuppressives and biologicals.
So this is the last talk, immunomodulatory treatment in uveitis. So before we go to the immunomodulatory treatment, it's important to understand the immunology of the eye as an organ and its immune privilege. We have certain barriers, as we all know, the blood-ocular barriers that prevent the free transport of antigen as well as antibodies across. As also, eye lacks a lymphatic drainage, and there are certain mediators like beta TGF, which are actually immunosuppressives. And also we see that the MHC class 2 antigens are much less inside the eye, and we also have what is known as the T regulatory cells or TREG cells, which actually act as immunosuppressors. So these are the reasons why eye act as an immune privileged organ, so it does not have the normal immune response like rest of the body. So this is very complicated to understand what is autoimmunity of the eye. It's actually complicated. This is the simplest form I could put this. So we have these T cells, naive T cells, which are released into the peripheral circulation from the thymus. That comes into the, when it comes into the eye, the dendritic cells capture these cells and present them as allo antigens to the retinal cells, and thereby activate this T cells, the retinal cells are presented to the T cell as allo antigens, the normal retinal cells. So the body reacts to those antigen by activating this T cell. T cell get activated into mainly 4 types, but what is important for us only these three types. So the T regulatory cells, that is the immunosuppressive cells, also get activated. So the balance, if the balance is on favor of the T regulatory cells, then no immunity happens. But if the balance is on the favor of the pro-immune T helper cells, that is the TH1 and the TH17. TH17 is a newly found helper cell. So if it is on the higher side, then they secrete these cytokines, basically the IL-2, TNF, etc., which are secreted and cause inflammation. So I try to explain to my patients based on an analogy. So where this immunity inside the eye is like well-trained dogs. So they don't bark at the owner, they don't even bark at some of the guests who come in. That's the immune privilege or the immune tolerance of the eye. But once this robber comes in his customary, his costume, typical costume with mask and other things, so he gets very angry and he starts barking at the or biting the robber. So that is the normal protective mechanism of the eyeball. But once a while the owner comes with this one of this part of the costume like a goggle or something, then the dog mistakes the owner for the robber and he attacks him. So that is autoimmunity. And what the owner does is he starts, in spite of having this goggle or something, he mask or something, he starts feeding the dog every day with some meat or something. So that slowly the dog's barking decreases and it starts liking the owner in spite of the costume. So that is immune training. That's what exactly immunomodulatory drugs are going to do. So I hope it helps how to understand the mechanism. So when do you consider immunosuppressive? So it always has to be at the back of the mind. Anyone treating uveitis, it should always be in the back of the mind. mind that you may have to use immunosuppressive, and it is important you bring in early. You understand which cases you need and you bring it in very early so that damage does not happen to the eye. There is no point after the patient going to counting 1 meter you start anti-immunosuppressive. So it has to be started early. So it is important you realize where. So these are some clues. You know the disease entity. Like it is Behçet's, where it is going to be chronic, relentlessly progressive, and results in optic atrophy. So you know this disease, your threshold to start immunosuppressive is very low. Or the eye is the other eye is lost due to uveitis. So that case is also used early on, start immunosuppressives. And some people, you are not, the maintenance dose, safe maintenance dose for steroid is less than 10 milligram, ideally 7.5 milligram per. If you are not able to reach that within 3 months, 3 months is the time in which you should attain 7.5 milligram. If it is not possible, those cases are candidates for immunosuppressives as steroid sparing agents. And some people are straight away intolerant to steroids. So those patients definitely you start much ahead with immunosuppressives. And in children, the complications of uveitis are so severe. So we have a low threshold for starting immunosuppressives in children. These are some of the common diseases, VKH especially. The treatment is most often not correct for VKH because many times once VKH recurs, then it is very difficult to manage VKH. So if it does not recur, it is very good. So once recurrence in VKH, or if VKH is not attaining remission within a period of 1 or 2 months, those cases you have to start immunosuppressives. Behçet's already told, JA in children, sarcoid. These are all few diseases where you have to keep in back of mind, you have to start immunosuppressives. So what are the prerequisites that you require before starting IMT? The patient should not have any active infection like TB. There should not be any hematologic, renal or liver disease. Patient should understand and should be willing for regular follow-ups and whatever tests are required in between, an informed consent, and patient should not plan pregnancy in that period. Patient should not receive any live vaccines, should maintain good hygiene and hand washing, and there should be meticulous follow-up and regular lab tests, as I told before. Objective documentation. Every visit you should, the AC grading of inflammation, everything has to be meticulously documented. And patient should always be instructed whenever you have a fever, just go immediately seek medical help and tell them you are on immunosuppressives. Good hydrations, no smoking, alcohol. These are the requirements. So the main concern as an ophthalmologist is, are these drugs safe? So we have some evidence. Before we didn't have any evidence. Now we have studies which have shown the safety of this drug. CITE is one such study. It's a cohort study which has shown the commonly used immunosuppressants. These are azathioprine, methotrexate and mycophenolate. These are the 3 drugs which we most often use. They don't cause, there is no increase in overall mortality or cancer mortality in this, right? Cyclophosphamide does not increase the mortality as such, but has a slight higher risk of cancer. And TNF inhibitors probably has a slight increase in cancer-related mortality. And this was another trial which compared multi-center uveitic trial, uveitic steroid treatment trial or MUST trial, where they compared systemic treatment with immunosuppressives as well as corticosteroids with regional corticosteroid treatment, that was intravitreal fluocinolone injection. So they found that if used properly, the visual benefit is better in the systemic group compared to the local treatment group. And you can safely continue this treatment for up to 7 years. There is no increase of systemic side effects compared to regional treatment. So it's very safe to start this patient, better than intravitreal fluocinolone. So how do you start? In standalone eye hospital, it's very difficult. So after a lot of doing it myself, most of the time I do it myself for these soft drugs. That's azathioprine, methotrexate, mycophenolate. But you can always, it's always better to involve the rheumatologist, especially if you have to go for higher drugs or if the patient's disease has a systemic component, then always rheumatologist should be involved. Also in special situations where the patient is pregnant. And the baseline investigations are complete blood count, liver and renal function. And at follow-up also these tests has to be repeated at 4 to 6 weeks interval, and anti-TNF therapy is very notorious for reactivation of TB, so tuberculin and quantiferon has to be done in these cases. So what is the aim of IMT? Is that the goal of IMT is to achieve a durable remission without steroids. So it is to remove the steroid from the treatment. So and it is usually achieved within 3 months of starting, and retrain the immune. So you are removing the immune memory. You are making the dog forget that issue. So that is what you are trying to do here. So and for ocular inflammation compared to other organs, you may need some more treatment. Most of the time it is 2 years, after which you can, if you have a completely recurrence free in 2 years, then you can start tapering these drugs. Pregnancy is one area of concern. Azathioprine appears to be safe, and we have some class B drugs where we have not proven any teratogenicity like infliximab, adalimumab, etc., which can be used, but always, as I told, involve your rheumatologist as well as gynecologist. I'll just briefly go through the common drugs. Methotrexate is an antimetabolite of folic acid, and azathioprine. These are the two most often used purine nucleotide analog, which suppress inosinic acid synthesis and decreases T and B cells. So this cohort of site looked at methotrexate, and they found that eye inflammation is completely subsided in 66% of the patients in 1 year, which is actually much more than cyclosporine, and only 13% of the cases did have no beneficial effect, and the rate of complications was less than 16%. So this is a very effective, safe drug, methotrexate. Mycophenolate also with 53% and 73% remission, 53 at 6 months and 73 at 1 year remission. It's a very effective drug, and only 12% patients had complication. And the newer drugs, we have the biologics, which actually block the cytokines released by the T helper cells. So they are very useful, and one of the most standing out drug is adalimumab because of its evidence that we have now for this drug. It's a monoclonal humanized antibody that inhibits TNF alpha, and it can be used subcutaneously, and it can be it's like a pen which can be injected used by the patient themselves once in 2 weeks. And it has been approved by FDA for use in childhood refractory uveitis. And the studies have shown that it is the most effective among all biologicals for JAA, and it is the 35% of the cases where it is refractory to any other biologicals like infliximab or etanercept also, it gets infection control. So it is one of the most useful, especially in pediatric cases. And these diseases like Behçet sarcoids also, where your routine immunosuppression fails, you can use adalimumab. It's a very useful drug. There are these trials like Visual 1 trial as well as Visual 2 and the Sycamore study. This was in pediatric population. So they have definitely shown the efficacy of this drug in controlling inflammation. Rituximab also is a newer biological drug, and it's found to be effective in this subgroup, diffuse subretinal fibrosis with uveitis syndrome. It is found to be very effective. And you have the newer biologicals also like golimumab, tocilizumab, and dacilizumab. These are also found, even though we don't have large trials, but they are all found to be very useful in uveitis. So to conclude, as I told earlier, the biggest problem of uveitis is you are starting many times steroids late or immunosuppressives late. By the time ocular damage has happened, we should have zero tolerance to inflammation as far as uveitis is concerned. So whether steroid or whether immunosuppressive, it should be brought in the right time, and you should understand that these drugs are safe if you are using them in a proper way. Whether it is steroid or immunosuppressive, they should be used properly. And you should bring in as early as possible so that you get better visual outcomes from these devastating diseases. Thank you. I think we can take the questions now if anybody has. We have a fantastic panel here. You can ask if you have any doubts.
Prakash, would you start with steroids as with the immunologicals as the first line of therapy in any situation?
No, sir.
Not even juvenile arthritis?
I think the pediatric uveitis, because we cannot keep the steroids on for a long time because of the side effects of the steroids, because that is the indication where you need to start them on immunosuppressive as early as possible. Even topical steroids is supposed to cause cataract in this pediatric population. So I think that is one indication where we are starting steroids immunosuppressive faster. And one more condition I found is Behçet's vasculitis, because this patient, the neovascularization develops very fast. So I think so we need to have a very intense control. So we need to add both the drugs together because by the time we taper again, the time is lost. So we need to add it a little earlier compared to other diseases.
Which vasculitis did you say?
Behçet's.
Okay. Anuradha, is there any minimum list of investigations that you would say, well, at least do this much, the rest you tailor?
Before starting immunosuppression?
No,
Yeah.
before starting any treatment. The patient comes to you for the first time.
Okay, so I will do complete blood count, ESR, Manto, chest X-ray, TPHA. VDRL, I would do it only depending on the positivity. Everything else is tailored. It depends on the situation, but these tests I will do for almost all cases.
Is that because syphilis is the great mimic and tuberculosis also is a mimic? I mean, tuberculosis doesn't, now mimic, let's say it can present in hundreds of ways.
With syphilis, that is correct, it's a great mimic. With tuberculosis, it's because you want to rule out even latent TB, before you start systemic steroids or immunosuppression. So it's not just for the diagnostic purpose, it's also for the treatment part of it.
Given a choice between intravitreal injections or the slurry form, the centrifuge form of steroid, or the suprachoroidal form, would you prefer those or would you prefer the oral treatment?
I think it's very difficult to say one drug because in uveitis it's always a, we need to... Within steroids, yes, that's what I said. If it's a bilateral disease like a VKH, I would prefer an oral steroids than a thing. Of course, if the patient is pregnant presenting with a VKH, then definitely I would go for an intravitreal or must be we need to try the suprachoroidal where Dr. Ajay Arora was talking about. I think that will have less side effects than this. Yes, bilateral VKH, oral steroids. I mean, definitely pregnant ladies, intravitreal steroids.
Does the reverse hold? Supposing it's a unilateral disease, would you go for intravitreal steroids instead of oral steroids?
Again, as I said, the investigation, because most of these uveitis are autoimmune causes or tubercular related. So I think treating one eye, because we know that very soon the other eye is going to get involved. So treating, of course, if there are a lot of contraindication for an oral steroids, then yes, I definitely would prefer an intravitreal steroids.
Prakash, if cost is not an issue, would intravitreal Ozurdex come high on your list of treatments?
Yes, sir, definitely. For macular edema, uveitis induced macular
For
edema.
uveitis.
No, for uveitis per se.
Plain pars planitis, moderately severe pars planitis, would you, one eye?
I think I would prefer to go for systemic treatment in those cases.
What about you, Anuradha?
I would go for Osidex. I would.
Yeah. Do we have any questions from the house? Is there anything bothering you people which you want to, subject? Ajay, it seems you're about to ask a question, but...
I said the basic problem is I don't have adequate trials on suprachoroidal, but what preliminary data which I have, and if it shows that the IOP doesn't rise, the cataract doesn't form, and we can safely inject it, I think we should be able to inject more because it reduces your cost. And centrifugation is very easy. It can be done outside your OR itself. It doesn't cost at all anything.
But apparently the problem is that it still does have a fairly significant incidence of raised intraocular pressure.
No. It does not have. In all our 98 eyes, though we had treated them with presumptively on brimonidine for about 3 weeks, and that was stopped. The effect of triamcinolone was there for much longer time. So the drug was effective, the glaucoma was not there. So therefore, and it's been shown by various studies, the amount of triamcinolone detecting in the anterior chamber is very little, very hardly anything.
Okay.
It's a closed space.
Yeah, thank you. One more question. I mean, patients with serpiginous, today, there's a fad, everything is tubercular. So, and there are various ways. If you can't say tubercular, you say presumed tubercular. Say presumed tubercular, so you're giving anti-tubercular treatment. First of all, what do you mean by anti-tubercular treatment? Are you talking about the full gamut of treatment for 4 drugs now being extended again back to 9 months? Or are you talking about just prophylaxis? 2, would you give it to every patient who comes to you with serpiginous choroiditis? Both Anuradha and...
Oh, okay, right. So, yes, we do see, we have seen patients with serpiginous choroiditis who have completely responded to ATT and steroids. But we also see a large chunk of patients, in spite of a Manto or a quantiferon TB being positive, going on to have active inflammation in spite of 6 months or 9 months of ATT. So generally, in our case, we limit ATT to the old regimen, which is 4 drugs for 2 months, and then 2 drug INH rifampicin for 4 months. We've been seeing a lot of ethambutol toxicity with the extended regime, and even if they're taking ATT from outside, we tell them to discontinue ethambutol after 2 months. Yeah. So, yeah, that's my take.
The thing is, I think there are few indications where when you look at the fundus picture, we know that we're dealing with a serpiginous choroiditis or a presumed tubercular choroiditis. I think the inflammation, the age group, because the younger age group always you think it is serpiginous choroiditis. And the second thing is the inflammation. Whenever we see an inflammation, we think again towards the tuberculosis. The second thing is along the
I'm sorry, I don't get that. It is inflammatory, no? So what do you mean by inflammation?
No, I'm just saying about starting on ATT.
Yeah,
this
so I mean,
patient. No,
what I'm talking about is active
Like,
serpiginous
when
choroiditis
we
is
have-
going to have inflammation.
No,
So
but-
when would you consider
Start.
anti-TB?
Anti-TB is, as I said, is if we know that lesions are along the vessels, we know that we are could be dealing with a tuberculosis. Because we've seen some of these patients come back once we stop the steroids, having the recurrence in the same eye or in the other eye. So some of this, when you look at the patients back retrospectively and the patients who have started on ATT, we have not seen much recurrence in this patient because they progress very fast, some of them. So the macular threatening is very important because most of the patients have good vision. So once the lesion comes to the macula, there is, the drop in vision, so that is one indication we would prefer, starting on ATT.
So even if the MAN2 was negative?
No, I think to consider, it's just not one investigation we look into thing. One is we always do a MANTO, we do a quantiferon TB goal, and nowadays I think HRCT chest is one more, what we always,
So
and among the
supposing-
three, if we have two of the things positive, then we always err towards it and we treat.
If you only have MAN2.
Manto, no, I don't take Manto into consideration
Okay,
alone.
what about a MAN2? Is there any value of the MAN2 that is significant?
Of course, normally I always look at the patient's reaction on the hand, like how it is more than the report what the lab gives. If I see a lot of necrosis and thing, I know that it's more significant than just having what the lab gives us.
Okay, so I think the pulmonologists don't consider a MAN2 of less than 20 now as important. They give significance to it only when it's more than 20 and 15 is borderline, and below that is not really considered as relevant. So supposing you have only MAN2, it doesn't become a MAN2 of say 10 is not an indication that it's positive. And if it's the only thing, it's not tubercular. So that's why I think one message that must go through is that every case is not tubercular. And I am more worried about getting an epidemic of resistant tuberculosis thanks to this kind of unnecessary anti-tubercular treatment being given when it's not indicated.
Can I ask a question?
Yeah.
So if to Dr. Anuradha, if you have a patient who had HRCT chest positive, MAN2 positive, quantiferon positive, was given ATT, I presented that case who came to me in 2014, treated with ATT and steroids. Comes to me 6 years later with a recurrence. And now we do HRCT, those are all old lesions. We treat them with steroids, he responded very well to preparing. Is there any role of repeating ATT?
I don't think so. It's already treated.
Yeah.
I think one more thing, the CORD study by the PGI group have enumerated how do we diagnose an ocular tuberculosis and how do we treat. Like they have a lot of algorithms and they've come to a consensus when do we treat with it.
What do we give them?
I think
We are not bothered about what they've done. The question is what do we tell them?
I think that's what the USI is.
Okay, I think Minija doesn't want to give you any more information now. So maybe it's time for us to say goodbye for today. And I think we've got a beautiful opportunity to at least discuss some of the basics. It's enough to keep your mind thinking. First of all, remember, this is something I used to say from the time when I was a faculty member in AIIMS. The cumulative knowledge of this group, of any group, is more than that of the lecturer. So please don't underestimate your ability to decide what is right and what is wrong for the patient. Use the information you got today to go and look back, study, think, and apply it on your patients. Don't take it blindfolded. So thank you very much, ladies and gentlemen. I think we've given you enough food for thought, and hope we'll see you next year.